18-year-old college student at Napa Valley College. He's a freshman. And he is going there to play baseball. And at the time, they had a pretty decent baseball program. The only reason I connected with him is I used to go volunteer there. I'd see patients once a week with the trainers. And so that's how I got him. But he pitched in high school. He's left-hand dominant. He's right now competing for an outfield position because they have a stacked pitching roster and they don't need him, and he's not apparently good enough. He also delivers Domino's pizza. I didn't really clarify how often. And his main complaint is he feels weak and his throwing does not feel coordinated. And he thinks that these current symptoms that he's had for not a very long time are directly related to that issue. Okay? So remember this part, the feeling weak and uncoordinated. That's really why he wants our help, although these symptoms are relevant for us. Okay? So as you look at the symptom profile, aside from his chief complaint, what primary, secondary, tertiary hypothesis, and maybe a non-musculoskeletal hypothesis come to mind? Speak now, or I'll call on you. Okay? And you say facet versus discogenic because?
Being pattern was discogenic, be one of Clark's point.
Okay, this is a good start. Good. Everybody agree with that statement? Could it be discogenic?
Could be.
Okay. I'm not funking on you, I'm just being devil's advocate. What's the likelihood of an 18-year-old having a facet arthropathy that's bad enough to refer it into a big area like that? Yeah, we don't know anything about his history. I mean, for all we know, he had an injury when he was 10, and now he's got a big, ugly joint. But a facet problem should be on your list, but who would say we should have a discogenic issue here as well? Yeah, and this big pattern here, 5, 6, 6, 7, if you remember back to some of those Dynatones we had kind of covered back in the day. So thank you for being bold enough to bring this up, but this is a good discussion. This is why we're having these discussions, because you would say facet, well, maybe discogenic more than facet, but facet can be in there. Okay, what else?
Your rotator cuff pathology, which is because he's a thrower.
Okay.
Or squat.
So what kind of pathology?
Maybe like tendinitis or tendinopathy.
Okay. So we know that, young people don't get tears. You can, it's not impossible, but certainly full thickness tears are not an issue, but maybe like a bad bursitis, certainly a possibility. Does the tingling fit in with a bad bursitis? Could it be two things? Could he have a neck problem and a shoulder problem?
Yeah.
Okay. Yeah, we don't know, again, anything about history. What else?
Like an AC joint issue potentially. I don't know that would explain everything, but that could be part of it with his throwing mechanics.
Okay, what do AC joint problems look like? What's their pain presentation, generally speaking? Yeah, so we're not the behavior yet, we're just talking about a picture. So anterior joint line pain, posterior joint line pain that runs on the clavicle, or just pain right up there. It's usually up here. Not that it can't, things always surprise us. We see things and we're like, there's no way it can be this, and then it is. But generally speaking, this is not a representation of an AC issue, unless he has had trauma, which he hasn't had trauma. Okay. Anybody want to explain out the tingling? Does it look like a pattern of anything? Where do we see tingling when it's a cervical problem, usually? what's the most common area that you'll experience tingling if you have a nerve root problem?
Fingers, hands.
But hands, right? Doesn't mean you can't have it proximal, but this is kind of like, this is weird. Weird, he's young, he's got this broad area of pain. It's sharp, it's catching, but it's a resolving ache. The whole area ached a lot. What about a non-musculoskeletal condition? Could he have a central nervous system problem? The first presentation of a brain tumor?
Hopefully not.
Hopefully not. Do you want me to go with that? I mean, what non-musculoskeletal problem would make you think of this?
Would that be too high for like a lung issue?
No,
Yeah.
but it's left side, usually, I mean, it can be.
Mhm.
I think more cardiovascular.
Okay, so just something cardiovascular. All right, so who wants a brain tumor? Who wants cardiovascular?
Let's go cardio.
I want neither.
Yeah, right, so, but you look at something like this and you gotta have that, you know, what could it be? It could be a lot of things. It could be, you know, some type of toxicity, whatever. If it's just, it's not, if you didn't have the tingling there, you probably think, well, that makes some sense. People can get broad areas of pain when they're young. And then you have to think about peripheral nerves, right? There's axillary, there's supraclavicular, and then there's all these cutaneous nerves that are associated with radial musculocutaneous and so on. You think about brachioplexopathy. He was a throwing athlete. And throwing activities can stretch the brachial plexus. You could throw a peripheral nerve condition of some kind in there. That would maybe explain weirdness, right? Where we're looking for something that's more dermatomal and it doesn't completely pass the sniff test. Not that you wouldn't put that in there, but you could say this could be maybe something brachial plexus related. I don't know. Okay, so here's his aggravating activity. This is not him. This is one of his teammates. So when he throws a baseball, intermittently he gets sharp pain in the shoulder. So qualifying where sharp pain is it sharp, whole, broad? No, it's here. It's in the shoulder joint itself. If he keeps throwing, his resting ache becomes more noticeable. At one point it was constant, now it's intermittent, but if he throws, that resting ache comes on. And then he says the direction of his throwing, the distance, and the velocity are all compromised. His control is bad enough to where, you know, if he's throwing the ball hard at somebody, he can't guarantee it's gonna go where he thinks it's gonna go. What does it make you think of? What helps us be precise with things that we do?
Proprioception.
Thank you.
Yeah.
Proprioception. So just like, okay, what does this make you think of? Corey was saying it a little bit earlier.
Late joint. Sorry.
So, yeah, it could be something subacromial, it could be a slap lesion, things like that. He's not saying clicking, popping, or anything like that, but this intermittent feeling of sharp catch could be that. If he sleeps left sideline, it makes his shoulder ache, and then he wakes up, he gets out of the position, but it'll keep him awake for 15 minutes. So he's not tolerant of being on that shoulder. And that's his ache. So what does that make you think of? Come on, you guys.
Bursa issue or
Yeah.
tendon issue.
Yeah, something subacromial, it could be a tendon issue because your rotator cuff, you're laying, right? So we lay on the shoulder. Nobody lays on their shoulder right on it, right? You spin out, now you have a RPA pressure on your shoulder, and that cuff is trying to keep it there, so the cuff is getting overworked. And if it's annoyed, it could be symptomatic. Then he says the tingling is random. It can come in the day, it can come at night, there's no pattern. And I questioned him about this. I'm like, so morning, midday, nighttime, or evening, it doesn't matter when. Do you ever wake up in the middle of the night with it? Sometimes I notice it at night. But I notice it in the day maybe more. So, no rhyme or reason, but he said it'll last a few minutes. He knows it's there, it's intense enough to know it's there, and it happens 8 to 10 times per day. Is it helpful for you? What would you ask him? What are some close-ended questions you would say at the time?
What position are you in?
What position are you in? Okay. And then he's like, I don't know. What would you ask him as a follow-up? Because what's your hypothesis? C-spine, shoulder, weird stuff. So what would be a good follow-up question?
Any history of neck pain?
Neck pain, but at the time when you're getting your numbness and tingling, are you on your phone? This was like pre-smartphones, so I don't know. Never asked. It was the flip phone era. You could take
Back when
pictures.
you could text without looking because it was the keyboard texting.
Oh, yes. Okay, it was miserable. Okay. So you could ask him, like, what position's your neck? Are you looking up? You're looking at the side? He's like, no, I don't know. So there's no aha moment coming from your behavior or symptoms. What about your arm position? Is it overhead? Is it behind? I mean, where's your arm? He couldn't answer any of the questions. So there's nothing, and he's a smart guy. So he would give you information if he could. So far, what do we think with what we've got here? Is there any movement on our hypothesis formation?
Who picked shoulder primary? Raise your hand. Nobody?
These symptoms seem more shoulder to me, but
Okay.
based on they seem more shoulder.
Yes.
I love it.
His main complaint is his inability to be accurate and have enough strength to throw the ball accurately and maybe proprioception. And he tells you when he's throwing the ball, it's a sharp catch. So
That's
he's
it.
probably got a shoulder problem, as far as we know. But then that doesn't explain the tingling. Okay, so we have good. So this is like, okay, looks like a shoulder problem. Okay, so if you thought subacute C5 radiculopathy secondary to C4-5 disc prolapse, and the paresthesia was elicited only after throwing for 10 minutes, what would that do to your hypothesis formation? Does it help it? Decreases?
Right. If you're thinking more shoulder versus less neck, then goes down a little bit in what you're weighing, right?
Isn't your neck doing weird things when you're leaning? Some extension if you're going really hard.
I don't know, what does your neck do when you throw?
I think you're
I like-
Sure,
Yeah.
yeah, I mean, your thorax is rotating, your head is staying forward. So if I'm rotating this way, I'm going into effectively left rotation in my C-spine. But does this make a difference? Do you say, oh, throwing makes it worse, I think it's putting tension on the nervous system, that would help this, because I think it's a C5 radiculopathy. What does that do? Does that give you well, we're tensioning the C5 nerve root, I'm giving it a +2, +1, is it equivocal? Does it change your hypothesis?
I don't think it changes anything.
Thank you. So you probably shouldn't change your hypothesis much. If you've got all these balls in the air, this is not a place that you're going to say, I have now confirmed I'm putting chits in my my cervical hypothesis. Okay, same hypothesis, left side lying elicits both shoulder ache and the paresthesias. What does that do? Huh?
Doesn't change because it's also, depending on the neck position, right? It could be triggering neck symptoms as well as shoulder symptoms. So
Yeah.
I would need to clarify
So,
head.
but he gets his paresthesias at the same time as he gets his shoulder ache. He's laying there on that side, probably no pillow, because he's 18, right? Doesn't need a pillow. He's hanging out. Wouldn't that be nice? I'm gonna lay prone for 2 hours. I'm not gonna wake up with a headache and tingling in my arm. God, that would be good. So what does this do, you guys? Come on.
Plus one.
Plus
Yeah, so it would make you kind of, if you associate these symptoms, I mean, we're grasping at straws here because there's no smoking gun. So if we were to associate these symptoms, we would say this gives us a little bit of this. Because his arm he's not throwing now. So you can see if he had a radiculopathy and he's tensioning his nervous system by throwing pretty hard, that would put tension on a sensitized nerve and it could give you paresthesias. But this doesn't help us move the needle here. This might give you a little bit like a +1, or if you're really in love with the Z-spine, then you could put a +2. But it would maybe say, maybe a little bit here, because these are associated. First rib syndrome. Paresthesia is elicited only after throwing. Does this look like first rib syndrome? Where is the paresthesias in first rib syndrome?
Exploring that whole inner distribution.
Yes. So does this help you at all? Why do I put first rib syndrome there? Because everybody thinks the first rib is affected in throwing athletes. As you muddle through the world, you'll find people, oh, it must be first rib. They're basing that off of treating it and helping people. I used to believe that, but it doesn't really fit the first rib syndrome. Doesn't mean you won't treat the first rib, but it doesn't give you, it's like equivocal, right? Okay, so here's his history. Now you'll start to pause more. Okay, so are you helped here? Or do you get some clarity? Look at it.
It's a little strange.
Strange, but when you hear, oh, starting with paresthesias, does that make you think of a shoulder problem? Outright? Yeah, it sounds more neck, right? Ah, it started with paresthesias. Good. This is gonna be a neck problem. And then it escalated through the evening, but it's still here, paresthesias here. I mean, maybe he's wired differently. We know people have a lot of different anatomical variations, so that could explain it. And then he gets shoulder aching and burning the next morning. So what does the burning make you think of, Manuela?
Nerve.
Nerve, right? So we have paresthesias, we have burning, nerve. Good. And so now, do we think it's a facet arthropathy? Or do we think we have a discogenic problem? Okay, so we have this big broad ache. We don't have a Cloward's sign, or Cloward's point rather, but we do have this big broad aching. It's burning, and then it starts to kind of decline. He has bad pain for 3 days. I'm sorry I never said, so what did you do for your pain? he probably iced whatever, I mean, that's what people do, right? And then he he didn't want to stop practicing because then he knew he was gonna be on the log pile or the wood pile and nobody was gonna remember he was on the team anymore. But he did go to the trainer, so it was bad enough to where he went to the team trainer and he's started noticing, gosh, what's wrong? This is like, I can't throw like I did. So if you're thinking a radiculopathy, right, which could be atypical, would you say that it's affecting the way his cuff is functioning? So you're thinking maybe like, gosh, maybe he's got denervation, he's weak. Okay. Who thinks he's got a C5 for Dick or a C6 for Dick?
Could be.
Okay,
Some aspects of it.
okay, good. Here's a little more history. So, his right shoulder dislocated, this is his left we're talking about. So this guy's maybe 5'9", 5'10", 150 pounds. We used to always say, when I worked in the training room at UCLA, that baseball players should never lift. They should just focus on core exercise and, doing like upper extremity perturbation and high repetition training because they always hurt themselves. Because they're not, generally speaking, baseball players they're not built for this kind of stuff. So this guy, if you looked at him, you would say, oh, you should not be doing deadlifts. And he's kind of a skinny kid. And not that he's not strong enough to do this, but he never lifted weights when he was in high school. They did this thing at Napa High that was called the Dawn Patrol, where they did Olympic lifting circuits, but it was not well designed. They had dads who volunteered to kind of help them lift and stuff, but he clearly didn't get much out of it. And now he's got somebody who's getting him up to 300 pounds deadlift. So do you think this could be a precipitant? Possibly. Yeah. Yeah. So, I mean, 80 pounds in each hand for shoulder shrugs, is that functional?
For, what, is he also doing combat sports?
That's my point. So,
Domino's Pizza.
right. Okay, so we have this information. We're back here thinking, well, some of this makes us think of a C5 radic, right? And so how many of you think right now that he's got a discogenic problem? Okay, me too. Here's his health screen and special questions. It's essentially normal. He has done prednisone a couple of times because of his asthma, but he hasn't been on it for quite a while. Anybody thinking AVN of the shoulder? Probably not. Yeah. He has a type 2 acromion on his right shoulder, and this is remnants from when he had a dislocation. And so when you have a type 2 acromion on one side, there's a pretty good likelihood that you might have it on the other. It's not a for sure thing, but it's possible. And of course he has a Hill-Sachs on his right too. Okay, so if you had to commit to something right now, what's your number one, and what percentage are you confident that that's the condition?
Probably the C5, C6 discogenic.
Is that what you think? Okay.
Based on history and precipitants that came out before his shoulder.
Okay. So what percentage are you gonna, how much money out of $100 are you gonna put down on that?
All the money I have.
Out of the $100, yeah, 60?
Yeah,
Okay.
let's say 6.
How about you, Ryan Angelus?
As a secondary hypothesis?
No,
or-
primary.
Oh, primary, agree.
Aaron?
Maybe a little higher, maybe 70.
Okay. Manuela? 65.
Yeah.
68.
Manuela's always gonna be different. How about you, Jennifer Ellis?
I was thinking 65 as well.
Okay.
Yeah, just a little bit higher.
Okay, how many of you think he has an intrinsic shoulder problem or a subacromial problem?
It's a primary, but it might be.
Why would he have a shoulder problem?
Pain inhibition. Pain inhibition to the rotator cuff.
Yeah,
According-
so mechanics are off because of something else. You know, if you have a stiff distal clavicle, your mechanics can be off and cause a subacromial problem or cause a labral issue. Okay, do you have a third hypothesis?
Quick question, Michael. So when with throwing athletes, I know it's kind of rare, but for some reason six gap came to my mind. But I don't remember.
Say that again.
Six gap, it's, I forget the acronym, what it means, but it's basically this coordination with the sacrothoracic muscles.
Okay, yeah.
Scapular dyskinesis.
Yeah.
Dyskinesia, yeah.
It's coordination.
Yeah.
So the question is, why do people have that? And that's a diagnosis that's still around. There was one particular sports medicine doctor we had in Vacaville. Anybody with a shoulder problem is scapular dyskinesia. But then what actually drives that dyskinesia? And when Gail and I did our subacromial study, our impingement study, the vast majority of people had that. And then you would treat the impairments and it would go away. Now, some people may not have that go away, and then you have to do very focused training. And when this scapular dyskinesia first became a thing back in the 90s, and Kibler was the person who really got it going, it was dual channel biofeedback. That's what the treatment was. And it was marginally effective because people had impairments still. But for somebody who doesn't have impairments that you could explain it away, that's kind of the next step, right? Or some types of hands-on care, designing a very focal, targeted program for how to train those muscles. But yeah, so that would be definitely part of this. I think that's kind of what Jenny was talking about, is scapular mechanics, glenohumeral mechanics change when there's a hitch somewhere. Do you have any other hypothesis you want to put up here? Cardiovascular, brain tumor, you still want to leave that here? I didn't check on his mentation, but he seems. I did ask him
Hey,
if
no,
he
times
gets
four.
tired going up and down stairs. Okay, all right. So this is not his shoulder, but this is essentially his shoulder. He's got wasting in the infraspinous fossa of his infraspinatus, obviously. And when he laid down, this is pretty typical. If you can see it in standing, it's fairly significant. When you lay down, you can see more subtle aspects of it. What group of people do we usually see something like this in?
Older patients with rotator cuff too.
Yeah. They have like multi-tendon rotator cuff tears. They have wasting, sometimes of their supraspinous and infraspinous fossa. He also has major fullness of the upper trap on the left side. Like it's just. What do you think that's there for? Is it because of the weakness, or is there something else that trap is turned on? Just kind of throw out all the possibilities.
Could be from shrugging, right? Like compensation with.
Okay. It's just the left side though. Maybe you shrug more on the left. What else? What is it? What happens when you see someone with a nerve issue with their neck? Do they want to allow shoulder girdle depression? No. So it may be a this is, again, throwing out all the possibilities, might be a protective mechanism. It's trying to keep the plexus and the nerve roots from being loaded. But it also, those things are present with just your garden variety chronic shoulder problems, although this is only 4 weeks in.
He's left-hand dominant, right?
Yes, he is.
So could it be some of it is just uses his left hand more, so the
Yeah,
attack is
so
more.
all the possibilities that you can throw out, yeah. Yeah. Okay. I should have asked you, what is your physical exam going to entail today? Michelle, do we do a neuro on him?
Yes.
Why are you doing it?
Crossing the joint, the tingliness.
The tingliness?
Actually, no, it's only here.
It's there, yeah.
I would still do it.
Yeah, so that would be an indication for it. Let's say he didn't have tingling, Michelle, and his pain was here, kind of in this area, but it didn't go into the scapular region, didn't go below the acromion.
Maybe not then.
Would you do that? Okay, but I feel like I'm weak, I don't have endurance, I don't have power, I don't have direction when I throw.
Yes.
And then the wasting, right?
Well, yeah, if you didn't see the
Oh,
wasting,
oh.
we're pre-shirt being off.
Would you do a full neuro, or would you do partial neuro and then decide from there?
I would still do maybe partial, just going off the coordination part and weakness.
What's the most important part of our neuro in a patient like this? Myotones. I mean, DTRs, you know, when do they get you excited? I
They're
mean,
hyper.
really excited.
Hyper.
But it's my
Yeah,
myelopathy.
if they're excited, yeah.
Yeah, when you have pathologic reflexes. Is a sluggish reflex, you go, oh, you have a sluggish reflex. But they're probably gonna have weakness too. So the myotonal testing is really the most important thing. DTRs clearly is, we're looking for something pathologic. Okay, so you're gonna look at his shoulder. We're gonna do a detailed shoulder, or are we gonna do a shoulder clearing and a detailed cervical, or vice versa? What do you think? Where's your weight from? You all said you're thinking a C5-6 issue.
This is after observation that we're talking about, right?
Yeah, so, yeah, pre-observation, would you all say I'm doing a cervical, expansive cervical with a neuro?
Yes.
Yeah, and then you look at this and you go, well, I don't understand why somebody like this, I mean, do you think he has a multi-tendon rotator cuff tear? I mean, if he was drunk and he fell off a balcony with his arm overhead, he probably still wouldn't tear his rotator cuff. Because he's 18 and the tissues are really good, he'd dislocate maybe, but he wouldn't tear his cuff probably. Okay, so you're kind of left with a big, I'm gonna respond to the emerging data. That's interesting. So you're gonna go into maybe your your shoulder clearing, and then depending on, as you peel the onion, you may decide I'm gonna do more of a shoulder exam, or I'm gonna stick with my original plan.
Also speaks to how important it is to take off the shirt and observe. Right?
Yeah. Far too often we don't do that. We're not comfortable with it, or, you know. Okay, so here's his cervical screening and his neuro. So what does this give you so far? What's one thing that made you go, okay, there's something? So he's got weakness here. Does this help you with your C5 radiculopathy? Yeah, So it's like, okay, well, that fits. What doesn't fit?
Life adjustments.
Yeah, what else? What would you see if this is a C5 predict?
Just be sluggish for at least 3
Okay, go back up the page a little bit.
Active range of motion, possible pressures.
Yeah, I mean, I cranked on his neck. I don't honestly remember if I sustained, but I cranked on his neck and there was nothing that shook out.
Did you do quadrant, do you remember?
Don't remember.
So that's, assuming that's just basic flexion, extension, rotation.
Do you think like for him being young, sometimes it will still depend with full range of motion?
Yes. Yeah. So, would you have done quadrant on this guy?
Probably, yeah.
Yes.
'Cause I'm hunting now.
This is who you do a quadrant on. This is, yes, you're hunting. You'd be aggressive. It's not that, oh, they just place you back here and they should put it over your hurts. No, you are, bam, getting in there and pushing hard. And I don't even know if I did that. I'm being truthful, but I'm glad somebody came up with that. You always have to, you did this.
That's what I'm here for, it's why you asked me to come today.
Okay, so what's next? What do we want to look at next?
Shoulder.
Okay, so here's shoulder. Okay, so here is your scapular dyskinesia. You have early and excessive scapular abduction. That's a pretty common thing you see with throwing athletes on their side that they throw with. And then you see it on swimmers quite frequently as well on both sides. Why do you think that is? What causes early scapular abduction? And it's easy to see when it's a unilateral fight because you can compare to the other side.
The lack of motor control.
Well, it could be that, sure. What else do you imagine is really tight on him?
Internal rotation, all the pecs
Yeah.
and everything.
That's,
So his infraspinatus is hollow. And so you're thinking, it's probably, you think denervation when you see that in a young person, until proven otherwise. And so a denervated muscle or a muscle that's denervated partially is going to be really inhibited and immobile. So that will make that, it'll drag it out early because there's no length there in the posterior capsule. Does that make sense? That's a real obvious sign of either just having tense external rotators, or in this case, tight external rotator for not a normal reason. Okay, horizontal adduction plus overpressure, full range of motion, gets a rest and take out of position. So for those of you who said an AC joint problem, does that make you think of an AC joint problem? Okay. Hand behind back, this is kind of our internal rotation test really. He moves only to L2. Would you expect that in a throwing athlete? Yeah, your throwing arm is usually has a loss of internal rotation. Glenohumeral quadrant, I wrote limited depth, so maybe 80% of the other side, a neural end field. What do I mean by that? It's like it's a weird, it's not like a hard thing, it's like this weird quivering. When you start to appreciate end fields more and more, I got this from one of my mentors, she goes, oh, that's a neural infield. What does that mean? Is it like a heart spasm? No, it's a neural infield. It's a nerve that's denervating, and that's the field that you're like, what? You know, there's no evidence of that. But he did have this very quivery end feel, like there was almost like an attempt to keep you from going further, trying really hard. So you'll feel it when you do upper limb tests on people who have a disadvantaged nerve. That's a neural infield. It won't just be like hard spasm stops you. It's this weird kind of coordinated stop. Okay, so this is probably not going to be very helpful, but if you think a brachial plexopathy secondary to attritional or acquired anterior shoulder instability. He's an unstable shoulder, the humeral head is slamming into the brachial plexus. If that's what your hypothesis is, and he says shoulder pain and arm paresthesia are provoked with maximal external rotation at 90 degrees of abduction and eased by a relocation test.
Yeah, that helps you, yeah.
Yeah, would help you, right? Yeah. Okay, you think the same thing. There's poor recruitment of both the infraspinatus, no. There's poor recruitment of the infraspinatus. And then manual muscle testing, the deltoid is 5 out of 5 and normal teres minor contraction, which is not true. This is not part of what we saw in our patients because the deltoid wasn't normal. But if this was the case, what would it make you, would it help you with this?
I don't think
No,
you
because you have the
Mm-mm.
normal cell switches and then
Okay.
C, and then
Okay,
more contraction.
so here is his group manual muscle tests. Go ahead and read through it, read through the whole thing, and we'll come back. So what are you guys thinking based off of these findings? What are the most profound findings on this page? Yeah, but he cannot hold. You get him prone, and he, you know, fortunately, he's very fit, so you can't do this on everybody. You could palpate the teres minor very easily. That's where he's getting a lot of his strength from, and he has sparse contractions of his infraspinatus. So where is your mind going at this point?
Peripheral nerve entrapment.
Yeah. And this impingement 2, he gets a resting ache out of position. Is that making us think he might have a subacromial problem? What else does this position do, though?
And stretching the posterior capsule.
Yeah, and the musculature that is blending into that. So it's maybe dragging the infraspinatus along a little bit for a ride. It's not very happy about it. Okay, so when you say peripheral nerve condition, entrapment, what peripheral nerve is this? Suprascapular nerve, right? And do we think the suprascapular nerve is out as a whole, or do we think it's part of an area of that nerve? Okay, so we don't see supraspinous fossa atrophy like we see, even though scaption is weak. Why do you think this is weak?
Because external rotations work.
Yeah, his brother isn't helping stabilize the joint, so it's inhibited, like we see throughout our practice. Inhibition's a big thing, but then you have to explain why is the scaption, you know, why is this or this so weak? if I'm not thinking that the supraspinatus, the supraspinatus is an issue, and that's probably why. Okay, so would you all palpate his C-spine for completeness? All right, so read through this. So this is a left unilateral PA, this is a left unilateral AP. Okay, so are you surprised by his palpation findings? He's 18 years old. These are the usual suspects, isn't it? When you have a shoulder problem, you end up with reflexive changes at the spinal level and in the thorax. What's the relevance of this? Very, very painful at the motor point of the infraspinatus.
Would that support like peripheral neuropathy or something?
Yeah, or it could support even some type of nerve issue. It could be C-spine, it could be a peripheral nerve. But if the motor point is not getting normal activity, it has to work harder to try and elicit a response. And it gets very painful. So, a lot of our patients who have long-standing chronic radics, if you go to the musculature in the lower extremity, upper extremity, it innervates, and you find the motor point, it is horrible. And it gets, the nomenclature used, mild fascial pain, but really it's driven by something else. And there was a big focus on this in the 70s. There were a couple of P&R docs in, I want to say it was Toronto, somewhere in Canada. And they looked at groups of people who had known denervation, and then they had a comparison group, same ages, and motor points were the big difference between the patients who had denervation or, long-standing spondylosis of the neck versus those who didn't. It wasn't perfect science, but it did tell a story like why this is something that we see. So here's the disposition for me. And a neuropraxia, there was no reason to have a neurotemesis or axonotemesis. You didn't have trauma. So there's something causing denervation of the suprascapular nerve, and it's distal to the supraspinatus. So I discussed with the referring MD, this was an orthopedic surgeon who would go to that same training room at the same day I would go. And the nice thing was, you would never want surgery with him. He wasn't a very good surgeon, but he would do anything you wanted. And so I recommended that the patient have an EMG. This was then. This is a long time ago. Today, you would probably get an MRI of the shoulder. We'll talk about why that is in a few minutes. And then get an EMG if needed for a differential. But I recommended an EMG, then I talked to the patient and I said, look, this is what I think is happening. The reason you feel this way is because this muscle is weak because it's not getting all the juice that it needs to contract. When you think about it, 4 weeks and he's got atrophy only, must be pretty significant denervation, not like a little bit. So I told him, you can't do anything upper extremity right now, or you're gonna hurt your shoulder, then you're gonna have more than one problem. And he probably, the sharp pain he's getting is, could be from intrinsic shoulder stuff. It also could be that suprascapular nerve is getting yanked on. And the suprascapular nerve doesn't have much of a sensory function. It's mainly just a motor nerve, except for it does innervate portions of the posterior capsule of the glenohumeral joint and also the AC joint. So maybe that's why this moved completely normal and coming out of it ached because we're dragging the suprascapular nerve around. And that's why he ached afterwards. So I told him, hey, you've got to use this opportunity to get yourself in tip-top cardiovascular shape. Because he admitted he doesn't do anything cardiovascular. I don't want to say typical baseball player, but at least the baseball players that I remember over the years didn't like cardiovascular training. And some were okay with it, but they'd make them, the whole team, like run around the periphery of the baseball field, and you know, you get these guys that are walking after one round through them. It's pretty funny, actually. Okay. So intervention. So I decided I wanted to see him a couple of times, just to make sure I kept that lifeline attached to him, because you know what happens with athletes when you tell them you can't do this stuff, you're gonna hurt yourself, and you think you connect with them, and then they talk to somebody else, or they go, I'm gonna do it anyway. So I wanted to be able to stay connected with him. I did that for a couple of weeks. He came down here to Vallejo and saw me. And then I saw him about once a month thereafter, kind of waiting for things to improve. And there was no training that I was planning on doing with him. Because what happens when you train a denervated muscle?
It's weaker.
Yeah, it burns out the motor points. So, and then you're waiting forever. So I thought, I'm gonna treat the axial skeleton. He's got some stiffness I can treat very easily, see if anything changes, which it did not. I treated the shoulder girdle impairments, which were pretty simple. It was AC stiffness, not SC. And then I soft tissued the infraspinatus just for the sheer fact that that thing is contracted down. Now, probably the smart thing to do would be, I could have gotten the galvanic stimulator to pop on that infraspinatus and use it once a day, just to keep the muscle from what? Atrophying more, or just getting fatty. So that's the big thing about galvanic stimulation, but you can't really, it used to be in every PT clinic, you know, but you don't want people to come in every day. So, and TENS units are ferratic, so you have to get a special galvanic stimulator to keep it from fatty degenerating. That's essentially what you're doing. Less important probably in a younger person, really important as people get older, because it happens fast. And then, you know, they use it 5 minutes a day. All it has to do is, in theory, the muscle has to contract like 10 times 5 seconds, and then that's it. And it's enough to keep the muscle fibers relatively healthy. So here's the EMG analysis. And so significant denervation, and as predicted, distal to the supraspinatus. It was mischaracterized as it's most likely due to a suprascapular notch, probably not that, but spinal glenoid notch, which we'll look at the anatomy on that in a couple of minutes. And then there's a few things that were relevant here. Spontaneous activity during the insertion of the needle. So you see this when you look at Spencer's or anybody's EMG test, not nerve conduction, but EMG. And so it said increased 3 on a scale of 1 to 4, and it basically means there's electrical distress. The motor units are attempting to search for a nerve impulse, which is why the motor point is going crazy, because it's like, hey, it's sending out signals. It's kind of like your cell phone when you're in a dead area and it's searching for a signal, and you don't have any bars and you're hoping to get a bar. That's the same, that's kind of my way of explaining it to patients. I couldn't do that then, because nobody thought about those things then. And then volitional motor unit activation potentials. Remember that? MUAPs? They're increased. It means that the nerve is being required to serve more muscle fibers. So the little innervation that you're getting, all those muscle fibers are saying, hey, 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 I'm over here. That's kind of what that means. This I totally understand. This makes total sense. It's not synonymous with this, but I'm taking care of Spencer right now in his neck. And I've been talking to him, he's like, oh, you don't need me to come over there, you guys are so smart, you know this stuff. Like, Spencer, no, we don't, because your reports mean not much to us. So,
It's a
and the
different
only
language.
reason I got this information was I went down and talked to him. And he's like, oh, let me explain this to you. And he's so funny, he talks to you like, he's a little kid, and you're the parent, you really know this, but I'll explain it to you anyway, because you're my parent, you're asking me to explain it like it's a test or something. But he's really smart, I don't know why he acts that way, but it's pretty funny. Okay, so about suprascapular neuropathies, like in prevalence in shoulder pain, it's 1 to 2%. It's like maybe 2 out of every 100 people you have coming to see you for a shoulder problem might have this. That's actually, pretty significant number. It's very overlooked when it comes to shoulder pain and disability. And in athletic populations, in people who do frequent overhead activity, lift heavy weights, it can be up to 1/3 of people with shoulder pain. So, the way volleyball players has always been the poster child for this. I think it's because of the ballistic nature and not having your feet planted on the ground maybe has something to do with it. But I don't know. I think throwing athletes is probably a pretty big number as well. There's an article that I sent you. I haven't read it. It's a redo of a previous publication, so probably better. Take a look at that. It covers really all the peripheral nerve issues that you run into. So the clinical features, and this is, doesn't mean it's everything, but it is pain that is dull, poorly localized, primarily the posterior shoulder. So that's kind of what we had. It might radiate to the neck. It may include paresthesias. Burning is another thing that's common. That burning sensation, even though doesn't have a lot of sensory stuff, but burning is a typical thing. And it typically increases with horizontal flexion. So if you have a young, healthy shoulder and you're able to move it as far as we did, because otherwise it's kind of like, it would be equivocal. You put the 0 down, you go across, somebody has a really stiff shoulder and it hurts, you would say, well, I probably have an AC problem. I can't say for sure it's nerve. And then there's always tenderness in the suprascapular notch, whether it's down the chain or not. Or I would imagine the supraspinous or supraspinatus is very tender when it's denervated too, like any denervated muscle, but the motor point of the infraspinatus is usually always fired up. And it's easy access. It's right kind of in the middle of the muscle. You can feel it. It's like a bump. So when the proximal portion of the nerve is involved, the pain is generally worse. Although his pain it sounded pretty bad when he had for the first few days. And then here's the other thing, it's sudden in onset, but it's like, where did this come from? And it's short-lived. So this is like your Parsonage Turner, where they have horrible pain and then they have weakness. So remember that. I mean, our typical cervical radiculopathies, do they have, oh, my pain's gone and now I'm weak? No, they're usually pretty miserable, and so that might help you. It's not pathognomonic, but it will help you in your clinical decision making, like what you're saying it is. When people tell you this, and then my pain was gone, that's pretty unusual. And then they're left with this weakness, maybe atrophy, depending on how much denervation they had. So when you think about the anatomy of the suprascapular nerve, how many of you remember the suprascapular nerve in your anatomy class?
I just remember there's like a notch that they talked about, the
Yeah.
suprascapular notch that it circles around. And
Yeah. And it's usually like one of the first things we'd see when we dissected that posterior neck and down into the plexus, because it's one of the, it's not the first nerve, it's one of the first nerves that comes off. So it comes off the C5-6, it heads through the posterior cervical triangle. This green circle I put in is it. It dives in there, and then it comes back. See this red thing here? That's the transverse ligament. I put the red there, it wasn't on there, so just so you know. And it dives underneath that. And so this is an area that used to be considered like, oh, this is where it all happens. But it's not so much. That ligament, for whatever reason, can get calcified and thicker. And then due to whatever type of activities the person does, it can become thickened and then close that notch a little bit. And then it's much more susceptible to traction type injuries. And then what it does is as it goes through here, it innervates the supraspinatus, and then it comes through here. You see this notch here? This is the spinal glenoid notch. And then it goes across. There are these motor points in the middle and at the periphery. Most of them are like right smack here in the middle of it. And so we look at it in another way. Here is that spinal glenoid notch, and here's the fake transverse ligament where the suprascapular nerve courses through. So it comes through. See this line over here? This is going over, innervating the supraspinatus, and then these are diving down the rabbit hole, and then coming out here from that posterior side. Again, a couple of other things. This is where you're, this is an anterior view rather, this is the posterior view of the spinal glenoid notch, the superior transverse ligament, and then it diving down. That's the course that it goes. So what is the etiology? You want trauma, like anything. You want trauma, okay, whatever form that takes. It can have, you could have injuries to it with dislocations. So that should be no surprise. You can also have the same thing happen to the axillary nerve as well. But dislocations, burners, so not a stinger, right? A stinger is a closing. A burner is when you get stretched out, and those nerves, which aren't meant to be stretched, get lengthened a lot. And because the suprascapular nerve is first in line, off of 5 and 6, it's more susceptible. By far the most common is a glenoid, or I'm sorry, a ganglion cyst. I know we always think of the ganglion cyst on the wrist, but it's an extension, it's a capsular wall weakness on the medial side of the capsule, posterior medial side. And a fistula creates, and then you get this big bulbous ganglion cyst. And that's what actually can cause the compression. And it's oftentimes after an occurrence of a SLAP lesion. The other thing can be ossified or hypertrophy transverse ligaments, and then things like neuralgic amyotrophy, like Parsonage-Turner syndrome. And this can be from a million things. The list would go on and on. Most commonly viral. You can have diabetic amyotrophy, so people who have diabetes that's significant enough can have like a single nerve, peripheral nerve, just denervate. Femoral nerve is pretty common. And then also suprascapular nerve is pretty common. Didn't you have one of these recently? Yeah.
Femoral nerve, though.
Huh?
Femoral nerve is the guy I saw.
Oh, femoral nerve, okay, yeah. And so, you know, this whole host of things, autoimmune disease is a big one, and then it is hereditary in some individuals. I don't exactly know why that is, but actually I do. It's not because of structural things. It's hereditary because of a protein marker that we all have that is present in greater numbers, and that protein marker has, or a protein marker, it's a type of protein that we have that can be deleterious to peripheral nerves. I've read about it a long time ago, and I can't pull it up from the hard drive at this but that's the hereditary marker. And then lupus. Lupus is another one that can cause these. Okay, when you think about pathomechanics, so the mechanics of this in volleyball, weightlifting, baseball, and you name it, probably lots of other things, the nerve is either forced up against the edge of the sharp inferior margin of the suprascapular ligament, or the scapular transverse ligament, and it can be made worse with shoulder girdle depression. So maybe that he did a little bit of that, but he didn't injure that part of the nerve. Retraction and abduction. These are the things that draw that superior part of the nerve up into the transverse scapular ligament. He did have some of that in his history. I'm assuming he would drop the shoulders all the way when he was doing his shrugs, and so that might have been a lot of load for him. Spondyloglenoid region, in some people, the nerve branches late and it's more susceptible to things like depression and external rotation. Whereas if it's not branching late, then it's not an issue. So the diagnostic modalities is that today, if the same person came to see you, you would say, this is what I think it is. You would recommend an MRI of the shoulder. And your hypothesis would be that they have a cyst in their spondyloglenoid notch. Or if they had wasting of the supraspinatus as well, you would say, this appears to be something that's proximal, so it would be transverse scapular ligament. And so that would be, you'd get an MRI done in Europe. Ultrasound is the primary thing that's used, same with like New Zealand and Australia. It's the first line of defense.
Question.
So, yeah.
So in this world of cost saving and not wanting to order an MRI, everybody, is it wrong to get the EMG first? I mean, I realize the MRI is going to tell you potentially why the nerve is compromised.
Yeah.
But the EMG is going to tell you that the nerve is compromised, and so
It is.
What would be the change in path then?
So
treatment-wise?
the last time I had this conversation with Spencer Wong, I had a patient with somebody that had a similar presentation. He's like, just get the MRI, and if it's normal, then I'll do the EMG. So there's no reason to wait this long.
Okay.
There's no reason for me to spend an hour with somebody doing this when, if it's positive, I'm gonna say, no, I need an MRI anyway
Yeah.
to see why.
Yeah.
And so, and his point was, if you have somebody with enough weakness and you have an MRI that shows the cyst, that's the issue. So he said, unless the surgeon says, I want to make sure that this is the case, he said that it's kind of silly to do that. And you put somebody through, needle poking, it's not just that they do that only. He's going to do a more expansive exam to make sure there's nothing else that can be driving the weakness. So it means he would put a needle in the spinal paraspinals to make sure it's not, spinal origin.
Quick question. What's the difference between an EMG and a nerve conduction test?
So an EMG studies the impulses that come to motor fibers in the muscle. A nerve conduction velocity test is a sensory test. And so an example, the easiest one, is looking at the median nerve, how fast the signal goes through this region. And there's a kind of a normal variation of 3.2 millimeters per second, centimeters per second to 3.8. If it goes above that, and you have symptoms that are consistent with carpal tunnel, then they would be able to say, well, you probably have carpal tunnel syndrome based off of this distal latency being slow.
Mm-hmm.
So it's how fast a sensory impulse goes through a nerve versus this is looking at the actual, whether there's motor denervation as well. So if you have a carpal tunnel problem, okay, and you go to see Spencer, he would first do the nerve conduction study, and then he would actually do an EMG on your hypothenar muscles to determine if you have motor denervation as well, because if you do and it's not real obvious, they want to do the surgery as soon as possible so you don't get more denervation. Let's say he does this distal latency and it's normal and you don't have denervation here, but he may actually come up higher up to see, or maybe distal latency is normal, but you have carpal tunnel symptoms. He may come up higher up and do the nerve conduction to see if there's something happening here like a pronator syndrome, which would also be indicative of having wasting in the hand because it just gets hit higher. Does that make sense? So nerve conduction, think sensory nerve speed. EMG, think muscle denervation or the health of the muscle itself.
Okay.
Because you can have one without the other on both ends, which is kind of weird. Usually when it's carpal tunnel, though, it's they're both.
Okay. And Spencer sees which one he wants to do. Like he'll.
Well,
or-
he has
or he
his
does too.
protocols, and then he
Okay.
responds to emerging data just like us.
Okay.
Yeah, he'll say, I'm going to investigate further. And so
Okay.
the breadth of an exam can go from something very focal to very broad if he gets things that don't look right.
Okay.
Yeah. Okay, so with the issues that are in the spinal glenoid region, you get this synovial bulbous thing that comes off of the medial capsule. It creates a mass effect. It compresses the nerve. That's how this happens. It happens slowly over time, and then eventually there's enough ischemia where the nerve shuts down. And so if you look at this case, this is a pretty drastic case. So this is a sagittal projection, T2 weighted, okay? So we're getting sliced this way. Good, okay. So this is a 16-year-old wrestler. He was a patient with Christy Green's back in the day. And she was sent to her for shoulder instability. She had profound weakness. Christy went down the hall, talked to one of the orthopedic surgeons. She was in this, we had a sports clinic that we used to run here. And he ordered an MRI, and so you can see like this is on the periphery, so this would be further out. This is the scapular Y area. You can see it very easily here. And the medial capsule is completely leaked out into this, or created a fistula with a huge ganglion down in the spinal glenoid notch. It was gigantic. And it's amazing that her, she didn't have complete denervation of the infraspinatus. She did have an EMG as well. So this is the sagittal. This is an axial slice. And so in that axial slice, you can see it from above. Here's the glenoid, see it? And back here is that big glenoid cyst, or a ganglion cyst that comes off of a little fistula connecting with the posterior medial capsule. And it catches it in that area. You can see it much easier here. You can see a little labrum there, but that again is that ganglion cyst. You guys all see it, right? Okay. You can't see the nerve because the nerve is buried in there somewhere.
So is that straight surgery? What?
She had surgery fairly quickly with Steve McGrath. And it was an open procedure, I guess. So your differentials are everything you laid out earlier. Intrinsic shoulder disorder, cervical radiculopathy or radiculitis, other upper trunk brachial plexopathies. I mean, it could be viral for all we know. And then the neuralgic amyotrophy, which is the most difficult to render differential, and that is mainly viral as well. Yeah.
How come it's like a sudden onset when cysts usually grow gradually and like that calcification would be a gradual process usually?
I think
is it
it's just
the activity?
finally it breaks the camel's back. Basically, you have ischemia of the nerve. And if you remember early on when we talked about cervical radiculopathy, and there was a picture of a tibial nerve from a rabbit. And they showed the tibial nerve from the rabbit unobstructed, and then tying a little string around that area and tightening it down, it started backfilling. And then you got all this edema collecting around it, and then eventually you have ischemia. That's what happens. It's just so gradual that finally there's enough ischemia the capillaries can't push through anymore. Okay, so here's our patient. This is a T1 weighted image. I put this on here to show you the value of the T2 weighted. So here is a coronal, right? This is a coronal image, and if you look right, I think here, and no, yes, but this is a coronal image. I think right here is actually part of his cyst. We're gonna go forward, wait a minute. Come back, yes. So this is what it looks like. It's this intermediate signal, so you really can't tell easily what it is. But you come into this coronal image now, and you can see it sitting there, right? And that as it's exiting from the supraspinous region into, so that nerve is coming down. Remember, it comes down here. So this is superior to it, here and here. And this is a little bit more in the norm as far as these ganglion cysts. They don't usually look as huge as Christie's patient did, but this is an amazing picture, and that's why I put it up here for you. Okay, so this is our patient, and so then what do? You know, he met with a surgeon, I think it was in San Rafael after all this came, and the recommendations were watch and wait. You're 18, you're probably gonna trim the corner, which doesn't make a lot of total sense because he has this ganglion cyst, right? And he's quite denervated. Non-steroidals and analgesics. Of course, now he doesn't really have any pain. There's no great benefit. Activity modification, he's already doing. They said go to PT, we were already doing. Next steps would be steroid injections into the notch. But this is not the notch, the superior notch. This is more inferior, so it would be impossible to get to. The next is considering an interventional procedure, a cyst drainage called Breesman. Basically, they stick a needle in there under an interventionalist's watchful eye, try to suck stuff out, and then go back into it and fill it with saline and try to explode the cyst. So draining the cyst, if you recall from ganglion cysts at the wrist, you drain them and they come right back. But if you slam them really hard, the whole Bible thing, right, or on a table like I did, I finally got rid of mine by bashing it into the table. And I felt it go, never had it again. So that's kind of what the Breesman does. And then there's surgical resection. So this procedure is not without risk. It's not an easy place to get to. The person who was that 16-year-old wrestler had a great outcome. It was a year until she had normal strength again, but she had a good outcome. So here's what happened with our guy.
Ben, do you remember how long she had symptoms before surgery?
She had a couple months worth of shoulder instability. Is what her diagnosis was.
Because given that it's the nerve, right, you think the length of time that it's denervated or the nerve wouldn't function properly is gonna make it no longer recover, right?
Totally, yeah.
So time is of the essence, kind of.
Yes, usually what they say is when you have denervation of a nerve, you get what you get after a year, but a lot of people get more than that after a year. I was very interested in the literature back in the early 2000s because I had drop foot from a Dick. And so, you know, I was reading everything I could and trying to make myself feel good about what was coming. And then right about 9 months, I started being able to, not use an AFL anymore, which was kind of nice, but some people never get it back. It's just, I think, risk factors are age, general health, that kind of stuff too. And a younger person, you have a different prognosis than someone who's a bit older. So I saw him 4 times. I also went up to the training room there and checked in on him. But I just treated his cervical and shoulder girdle impairments. He had better movement, and believe it or not, with his humeral quadrant, not normal, but better. Then I tried at week 12, that's right. We just said, let's try strengthening. He really wanted to do something. And so in the clinic up there, we used the spaghetti tubing, that really lightweight tubing. And we established a 12 repetition max on him. That's as much as he could get before he was really struggling to get out there without compensating, right? And then I made him rest for 3 minutes. That's really the maximum recovery time. If you look at I don't know what the strength literature says now, but when you're doing 3 sets of anything, your endurance recovery, and so essentially your next set will be probably 90% as good as your first set if you rest for 3 minutes. The old literature said 90 seconds, but for him, you wanted him to work that long. And then he did 9 reps, then he did 6 reps. We used kind of the DeLorme method of training, just you can't do that with tubing, but we did it with reps. And then he said, I talked to him on the phone, he was fatigued, he couldn't raise his arm for 2 days. So that says it's contraindicated to strengthen yet. And that was probably a hard conversation, but I said, your nerve is out. You can't expect, and to tell an 18-year-old that and have them really understand it is kind of hard. I got him, and he was doing cardio, so he was doing a lot of cardio, and then I had him self-mobilize the cervicothoracic region once a day, because I told him this is going to help you when you get back. It's going to help you bat, it's going to help you throw. That was the other thing. He wanted to do batting practice, did that a little bit, and then he was so fatigued, at the end of the week that he had been doing it, he couldn't do that either. He felt it. So I think that helped him understand. And then, there were other options for treatment, but he wanted to do the watch and wait. Okay, so here we are, 6 months post-injury, if you want to call it that. His strength came back, and I tested him 25 reps, prone, full external rotation, and he was able to hold against me. So if you can hold, because they don't have a Cybex machine there, they didn't have anything to test his strength. So we just manual muscle tested him over and over and over, 5-second holds, held against me, like, good, let's do it. So he used a return to throwing program, that kind of the one we have here, but he could do it twice a day. And he kind of sailed through that. He did really pretty well. Starting at 9 months, he made it into that, time period where he could get, what do you call it when you do an exhibition. And then he got into Sac State, which is they have a really good baseball program at Sac State. It's a feeder for a lot of other schools and for some of the minor leagues as well. But he had a recurrence, same exact scenario. He knew exactly what happened. And his parents live in Napa. He came back, he was under their insurance. He didn't want to do surgery, but he finally consented to an aspiration and bereavement. The thing is the aspiration and bereavement may or may not have helped him, because the person who was at Richmond at the time that was really good at this had left for a while, when a sabbatical came back, and that person who would have done it probably had never done it in their life. But the guy that did his this time, he's like the mad scientist. He would do anything. He would breeze anything, inject anything, figure out a way. Christy Green had a patient with a Tarlov cyst, It's like a place that you never go, down in the sacrum, and he managed to get in there and actually explode a Tarlov cyst. So anyway, I went with this guy, and it took a long time. That was the thing I was impressed about. He had, they take these needles and they weave them around, they spin them, and apparently the outside of the needles have like a little traction thing on them. If you want to like go over there where Stephen is, I have to do this, and it'll kind of go that way. If I want to go that way, I go that way, and then to go down and up, it's a different thing. You have to turn and do it the other way. So he got into this thing, and he couldn't suck anything out of it. He said, then it's hard, it's hardened, it's probably going to require surgery, but then he had this pretty good syringe, and he just went, and all of a sudden on the fluoroscopy, it just went, and
You went and watched?
wow. Yeah, I went down there a few times. His name is Paul Coelho. He's no longer with Kaiser, unfortunately. I don't think they could pay him enough. He was so good. But he used to live in Yountville, and then he started to practice in Yountville, and he moved to Eugene of all places. And is practicing there, I think, still. So there are options for this, and now, none of our PM&R docs could do that here, but there's one at San Francisco that's really does almost everything. I don't like Paul Coelho.
So basically from that slide and the previous slide, you treated him and then you said, shut it down, let's rest. And then
Yeah.
6 months later, then he ended up having full strength.
Yeah, but not because he did anything, it just
Yeah.
kind of came back. And the interesting thing is, he was still atrophied. If you looked at his
Yeah.
infraspinatus, but he was able to generate enough power where I really couldn't, I could have broken him. I didn't want to break his
Ego.
ego or just
Spirit.
his spirit, yeah.
Yeah.
He really wanted to play baseball so bad. And he wasn't a macho dude or anything. He was a nice kid. And anyway, but I'm like, man, this is gonna be easy. I'm gonna break you so easy, but he was able to hold against me. So then he started training at that point. And then I don't even know what that looked like. It was a few weeks of high repetition, low load exercise, and then he kept saying, my shoulder feels good, and so he started his return to throwing program, kept strengthening. I have to say, I don't think that infraspinous fossa really filled up again. And then the next time I saw him, he had his recurrence. So I don't know if he bulked up and then it atrophied again or not. And then he was done. He decided he was gonna get it done and not play baseball anymore.
What about the in-between time, like when you tested him and had him rest, did you see him once in a while between them before the 6 months, or he
I
kind of
saw
was
him
on
at
his
that
own?
training room. That's
Okay.
really I saw him, but I wasn't really treating him. I was just checking in with him.
Yeah.
And he kind of didn't want.
Mhm.
This is pretty typical for athletic people, particularly if he's on the sidelines now. He really didn't want a lot of attention. So, I'd look at him, I'd talk to him and say, hang in there. But when he was ready to, he's like, I think I'm getting a lot stronger. I want to go back to strengthening, and so I met him up there.
So he just kind of did some stuff on his own and tested it
Yeah,
out?
I don't think he just felt, I don't know, maybe he did, maybe he strengthened, but he was using that spaghetti tubing for a number of weeks
Mhm.
and progressing with that. I think he'd get
Yeah.
kind of fried after doing that, even though I tested him, and then isometric is one thing, but to go through range is another thing as well, so.
And is there any consequences of delaying removing that cyst because he's increasing his
Well, I think it
elongation
was
of
what,
denervation?
yeah, I think it was what Kelly was saying was, the longer that nerve is shut down, the more Wallerian degeneration, or regeneration has to happen.
Yeah.
Or degeneration has to happen, so that conductivity takes forever, if it's gonna happen at all.
Mhm.
And then the second part is, that muscle, the histology of your muscle changes after being denervated. So So, and looking back on this, I thought, gosh, I don't know why I didn't figure out how to get him thoracic stimulation, because they certainly, and they have the Russian current machine at that little training room, and they use it on everybody for, ice and stim, but they could have used for, galvanic on him. But it never occurred to me, and I don't know why. But that would be, when you have a muscle that's denervated and you know it's gonna be a long time, I don't think we have galvanic in any of our machines here. I could be wrong, but I don't think we do. But you can buy little galvanic stimulators online. Hopefully about $50.
And the cyst itself, there's no, is it repetitive use of the joint that might cause it, or there's nothing, right? We don't know why. Just the same with the wrist ones
Yeah,
that come and go.
you have a weakness in
Whenever
the,
it please.
in the joint somewhere, and then it breaks out and bubbles up, and,
If he was like a returning patient here who's like, I need to come in and be seen, for someone like him, would you, treat the impairments, have him with the stimulator, and then just see him every 6 weeks to kind of check in on his strength, and then just when he seems like he's getting better, then go back if he was still really not wanting to do
I think it
the
depends
surgery?
on how okay you are with doing a TAV with them.
Yeah.
'Cause, once you've done, kind of established some type of program for them, which would be cardiovascular training, stretch your impairments, if that's all you're having them do, I think having them come in, you can ask them, though, do you want to come in to see me? I'm happy to see you, otherwise I'm going to connect with you every 4 to 6 weeks by phone.
Okay.
And then, here's what I want you to do, you can test yourself.
Mhm.
And when you can hold against reasonable resistance, that's when I want to see you back. Try to make it as economically possible or doable for them, but
Yeah.
like him, his parents had good insurance, I think, he didn't pay anything. Okay, any other thoughts or questions about this case?
Just a question regarding the galvanic current. Can you use that on patients with cervical radiculopathy?
Yeah, anything that is denervated, so I guess it depends on what's denervated.
Uh-huh.
Here's the one thing I can tell you, you need to kind of have a superficial muscle.
Yeah.
If it's a muscle that's layered under other muscles, like, the last time I used it was somebody with their serratus anterior. That was a huge challenge. I thought I was, because he had basically full denervation. I'm thinking, okay, I know it attaches here. I was putting it over that area, and I had all this crosstalk into the teres minor, I think, into probably the subscap. I'm like, what the hell? It was like not doing anything with the serratus anterior. Finally, I found the spot. I had to draw these big, I used a Sharpie, drew on him, took a picture of him, and then his wife would put the pads on him because he kind of had a hard time seeing what he was doing. And it helped. And his serratus now, I just saw him on Friday, is a 5 out of 5 again, but it took 3 years. And he had COVID, and then all of a sudden he had long thoracic palsy. Like 3 weeks after he got over COVID. And that's something, and that's the only thing, nobody else can come up with a reason.
COVID induced, long thoracic.
Well, that's what he diagnosed himself as, and he talked to a bunch of other people, and they're all like, I don't know, spontaneous long thoracic nerve palsy. Viral, right? Could be viral. So he certainly wasn't diabetic. It could be autoimmune, but was that related to the COVID? I don't know. Okay, so kind of a mind bender, right? Face value, we're like, okay, C-spine doesn't fit perfect. Shoulder, kind of, yeah, there's some shoulder stuff in there, and then you keep going through the process, and then, of course, the hollowing of his infraspinatus was there's something going on there, probably suprascapular nerve. But how many people have this and nobody ever looks? You know, Ryan had a patient a number of years ago, no, Chet had a patient a number of years ago, the chicken farmer. Did you guys hear about this case? And 38-year-old chicken farmer, and he brought me in and he had wasting with supraspinous fossa, infraspinous fossa. It was like, you know, you pour water in the supraspinous fossa, which is sit in there. And he's like, I think he has a multi-tendon rotator cuff tear. 30-some years old, there's no way. There's no way. And the guy was saying, yeah, you know, I grab overhead and I pull these chicken cages down with the chickens in them to transport them. And so I said, I'm sure he's got a suprascapular nerve issue. Well, we got an MRI on his shoulder, multi-tendon tears, infraspinatus, supraspinatus, subscap. And then he said, did you not have like some major pop? And I don't, he told Jack, he didn't remember anything. He just kind of started having a hard time moving his arm overhead. So never say never, but it's pretty unlikely that you're gonna have a full thickness rotator cuff tear, particularly multi-tendons, in somebody who's under the age of 50. So, and then Ryan Elliott had a guy who was 48 who fell, was like got pulled back into a kind of a dislocated posture, but didn't dislocate, felt a big pop. Same thing with him. He tore supraspinatus and infraspinatus. So you'd think it'd be subscap, but it was infraspinatus for whatever reason. Yeah. All right, you guys, let's take 20 minutes. Come back at 1:45.